I was like, oh, here it is. Sorry. Dr. Dhanani is an assistant professor at Northwestern University Feinberg School of Medicine with a specialization in infectious disease. He completed his residency and fellowship at Boston Medical Center and teaches at the teaching affiliate of Boston University School of Medicine. He also completed his fellowship in health professional education between finishing residency and beginning clinical fellowship. And Dr. Dhanani is passionate about antimicrobial stewardship and thinks system-level solutions to stewardship-related problems are urgently needed to protect us all. So welcome, Dr. Dhanani.
Thank you so much for your introduction. So I'm going to talk a bit about implementation of outpatient antimicrobial stewardship, the experience we've had at Northwestern over the past couple of years. I tell that cooking without a recipe, I think, I'm not trying to throw shade, but I think one thing we've seen a lot is that the CDC core elements can be very readily adapted to specific sites, but that means they're not very specific. And so I kind of felt like we had like some ingredients on our countertop, but not really an idea of how to put them together to make, French toast or whatever. So I'm going to try to explore that a little bit. So I have no relevant disclosures. I do have some objectives. So by the end of the session, I'm hoping everybody will be able to articulate key reasons as to why to establish an outpatient stewardship program, to describe the rationale for careful implementation here, so thoughtful implementation of that program, to identify some common challenges that would arise during implementation, and to understand some key metrics that we utilize to monitor performance of such programs. Okay, so the outline is actually pretty short, just why I think implementation matters, and then talking about our experience at Northwestern. Okay, so before we get into that, I think it's good to do a bit of a thought exercise, okay? And some of this maybe we covered earlier in the day with some of the earlier lectures, but if you think about it, if you were an employee of a network of primary and specialty clinics in a nearby city, and your job included oversight of quality and patient safety, you might have noticed that the Joint Commission has released several updates of its antibiotic stewardship standards for hospitals, but not for outpatient settings thus far. So if the outpatient standards follow suit, then how are they likely to change in the future? So you have basically different permutations of three options: more detailed, more stringent; less detailed, less stringent; more detailed, less stringent; or just unchanged. And so one thing I think it's important to recognize is the hospital setting standards become more detailed and more stringent with every iteration. I think it's reasonable to expect that the outpatient standards may also move in this direction. So just for some specific examples. So as we might recall, the outpatient standards went live in 2020. They haven't been updated, maybe COVID, maybe really trying to preserve that tailorability of the outpatient standards because outpatient settings do vary so much. So maybe some reasons they haven't been updated. But if we look at the hospital standards, they've clearly become more stringent. So, these are elements of performance here that I've pulled out from the standard. So the previous standard that I had in mind was that the hospital has an antimicrobial stewardship program based on current scientific literature, right? So that was the last one. But the current one that replaced that is that the hospital establishes antimicrobial stewardship as an organizational priority through support of its antimicrobial stewardship program. So that's quite a difference in terms of what message it's communicating. And just another example, previously, leaders established antimicrobial stewardship as an organizational priority, now changed to the hospital allocates financial resources for staffing and information technology to support the antibiotic stewardship program. So much more detailed and much more stringent, or you have to put money at this now. So as I mentioned, and as we've seen throughout the day a couple times now, the CDC has released core elements that really help us think about stewardship, but how do we introduce those core elements? And this is where I think thoughtful implementation is really critical to success. So it's important to recognize that leading stewardship at a facility is really a wide-ranging mandate. for that program, for that group of people. And it requires handling many moving parts to build a successful program. And so this is where the core elements can be helpful. And I'll go into detail about each core element, but in general, the four are commitment, action for policy and practice, tracking and reporting, and education and expertise. So I have text from the CDC up here on the slide that gives examples of how institutions can fulfill each outpatient stewardship standard. So the first one being commitment, to demonstrate dedication to and accountability for optimizing antibiotic prescribing and patient safety. So some examples: writing and displaying public commitments in support of antimicrobial stewardship, identifying a single leader to direct antimicrobial stewardship activities within a facility, including antibiotic stewardship-related duties in position descriptions or job evaluation criteria, and communicating with all clinic staff members to set patient expectations. Action is the next one I want to talk about. So action here is implementing at least one policy or practice to improve antibiotic prescribing. Not just implementing it, but also assess whether it's working and then modify it as needed. So some ways we do that: we use evidence-based diagnostic criteria and treatment recommendations. We use delayed prescribing practices or watchful waiting when appropriate. We provide communication skills training for clinicians. And we do things in the medical record. We require explicit written justification in the medical record for non-recommended antibiotics. We also provide support for clinical decisions, and we use call centers, nurse hotlines, or pharmacist consultation as triage systems. The third element, I think, has proven a bit of an interesting thing to tackle for us, is tracking and reporting. So monitoring antibiotic prescribing practices and offering regular feedback to clinicians, or alternatively, having clinicians assess their own antibiotic prescribing practices themselves. So some ways to do that: as I mentioned, self-evaluation. Clinicians can participate in continuing medical education and quality improvement activities to track and improve prescribing. Facilities can implement at least one antibiotic prescribing tracking and reporting system. And they can assess and share performance on quality measures and establish reduction goals on antibiotic prescribing that they may receive from healthcare plans or payers. Okay, and the last core element is education and expertise. So providing educational resources to clinicians, but also to patients on antibiotic prescribing and ensuring access to needed expertise on optimizing that prescribing. So some examples: use of effective communication strategies to educate patients about antibiotic utilization and when it's necessary and not necessary, and also educating patients about the potential harms of antibiotic treatment. That can happen through providing patient education materials. And then there's the whole clinician education side. So that's the rest of the slide here. So providing face-to-face educational training, which they also refer to as academic detailing, providing clinician continuing education, and ensuring timely access to persons with the appropriate expertise. Okay, so those are the CDC core elements for the outpatient setting. So question 2. So if you're an infectious disease pharmacist at a network of primary and specialty clinics in a nearby city, your role can make you responsible for creation and implementation of an antimicrobial stewardship program for just the general internal medicine practice here. We're going to focus on one set of providers. So which of the following clinical syndromes is an appropriate target for the first stewardship intervention? So I listed 4. So urinary tract infection, skin and soft tissue infection, pneumonia, and upper respiratory tract infection. So I think you could make an argument for any of these, but I think it's pretty convincing to me that upper respiratory tract infection is an appropriate target for the first intervention. So why? So of the listed syndromes, there's a lot of variation in how often antibiotics are needed. Think about UTI. Some people call things a UTI when they're asymptomatic bacteriuria, and also how complex each syndrome can be. So your UTI spans the range of cystitis to pyelonephritis with bacteremia. So there's a big range in not only appropriateness, but also duration, route, and the best drug that you might want to use. However, in adults, we know that upper respiratory tract infections such as sinusitis, non-streptococcal pharyngitis, bronchitis require antibiotics less than 10% of the time. I think even 10% can be a bit high. Pneumonia is probably not as common in outpatients as clinicians think, And I think it's a difficult one to flag as a first intervention target because it's hard to retrospectively, for outpatients, say this person had pneumonia 2 weeks ago if you're looking at that chart 2 weeks later. Skin and soft tissue infection, and I already mentioned urinary tract infections, that they vary widely in depth and in extent of infection, and their complexity makes them maybe not the best starting point for a new program. So AHRQ kind of agrees with some of this approach. So they rank respiratory tract infections in terms of appropriateness of antibiotic utilization. So I've listed not only the conditions themselves, but also the ICD-10 codes that match with it, which were important in some of our tracking and reporting work. And you can see that at the bottom there, the conditions that really don't require antibiotics on this rubric include acute laryngitis and tracheitis, influenza, COVID-19, right? Viruses don't need antibiotics. And close to the bottom are acute bronchitis and acute lower respiratory tract infection that's not pneumonia. So I think thinking a bit about the core elements here, there are a lot of work, it's a lot of work to meet them. I think they all make inherent sense as to why the CDC picked those elements and that language, but they are very interrelated. And I think that reflects the multifaceted nature of stewardship in the outpatient setting, but also in the inpatient setting. I think it's important to recognize that early successes can encourage organizational investment. And so you really want to build your stewardship methodology, your implementation, in a way that makes sense in the moment, but also leaves room for downstream growth. And this is one thing that we tried to do at Northwestern and are still trying to do. And so just some more detail about that is I think the first step is to really pick a well-defined condition where antibiotics are often overprescribed. Developing a tracking and reporting system that can expand without extra work. Say, you built it to address adults in the moment, but you think, hey, maybe I'll tackle kids 2 years from now. So building it in a way that allows you to expand it down the road without having to start from scratch. Identifying and utilizing internal experts. I don't see any of our Northwestern pharmacists in the room, but I'll talk about them at length because they were really invaluable members of the team, even though when I show the team pictures, they may not be there. They were still part of our larger team. Exciting leadership to encourage institutional support for a champion. We'll return to that point. And engaging with clinicians is really the critical thing here. I don't think stewardship can exist in a vacuum where you're sitting in front of your computer and not really talking to the frontline prescribers. I think that is absolutely critical. And I think the last thing that I would say is really important is sustainability. We all know that attrition occurs when the attention of stewardship turns from one topic to something else. But I think we have to build, despite that, we have to build a sustainable system. So I want to point out this paper. This paper is, I'm not going to pronounce this well, Dr. Deriga, a pharmacist at University of Illinois Chicago, actually. I think she's presenting in this room at 3:45, but I think this was a really nicely well put together paper that summarized some of the most recent evidence in how to design and implement an outpatient stewardship program. So if you're interested in this topic, I think this is a very good primer. It suggests the following ordered phases. So identifying champions, and then obtaining leadership support, and then a needs assessment, and then stewardship implementation after that, with tracking and reporting, and then looping back and sharing findings. So, oh, well, that wasn't supposed to happen. No, okay. All right, so if I can advance the slides, I think. There we go. Okay, so this is, I think, a really important inflection point as you're developing a new stewardship program is how many disease states should we tackle? How many types of stewardship interventions should we employ for each of those disease states, be it 1, be it 10? So looking at the literature, a multi-pronged approach that uses more than one type of stewardship implementation intervention, that kind of an approach more often has success, but like any checklist type problem that we run into in healthcare. It's hard to really understand the contribution of each element to the overall success. Single issue approaches, they focus on one problem, but I think those get challenging because those can really be context dependent. And, maybe clinicians in one system have a certain attitude towards upper respiratory tract infections that clinicians in another system across the country don't share. So I think that can itself be somewhat challenging. I will note that the literature that looked at this, each of these styles encompass all core elements. So you're not trying to implement one core element and not the other. That's not what I'm saying. It's really how many disease states are we tackling? How many types of interventions are we enacting at once? And I think there's a paradox here when it comes to strategizing your approach. How do you show change and executive buy-in before you launch and get support for your program? So I'm sure we've all struggled with that. So as I mentioned, I think on that continuum of attacking one issue versus many, that should really depend on institutional needs and capacities, and maybe how much you think you will get support for if you have a successful intervention. So I'm going to move on just to talk about what we've done at Northwestern. So we were very fortunate to receive the funding opportunity from the State Department of Public Health. It's titled Implementation of Core Elements of Antibiotic Stewardship 2023. I'll say we began our grant activities in earnest in late 2023. They are ongoing, and one of the key things that we are trying to do with this support is develop an implementation package that will provide a practical toolkit for outpatient facilities trying to realize these core elements. So we're trying to develop that recipe, as it were, as much as we can for, a couple facilities that won't eventually be places that are just starting, but we've established at that point. So some of our key participants are Northwestern University, Northwestern Medicine, and two of Northwestern Medicine's community partners, and then an external data warehouse. Our initial grant activities took place at the Northwestern Medicine Immediate Care Centers. This is a network of urgent care type facilities that see patients from as young as 6 months to, old age, and they exist throughout the Chicagoland area. Now, really a variety of rural to urban settings. Our later work, the work at the community partners and the work that involved the external data warehouse, occurred at federally qualifying health centers. So this is our core team. So Dr. Sutton is an associate professor with the Department of Medicine at Northwestern University and director of the Northwestern Memorial Hospital Antimicrobial Stewardship Program. You have myself, you have Dr. Evans, who is a professor in the Department of Preventive Medicine and a research career scientist at the Hines VA, and then Deja Glover is our project manager. So where is our project now and where did it come from? So initially, when we were in the early stages of this project, we tweaked some validated surveys for prescribers and facility leadership to complete to help us really understand what the understanding of stewardship was at that point at the immediate care centers. We also developed one-page guidelines, which I'll get into a bit and will come up in the next session, to really try to standardize our approach to 7 common infections seen in the outpatient setting. We, at that point, also made a data collection plan and started to talk to prescribers during staff meetings. And we started to develop a dashboard. Then, as we implemented, we also distributed some posters and brochures for clinicians and patients both to look at and maybe to help clinicians roll out stewardship to their patients in the patient-facing encounters. Actually, some of those posters are posted. We named peer champions initially at Northwestern and then later at our community partners, and we continued with staff meeting presentations. And more recently, we've continued our rounds of surveys to deepen our understanding of stewardship at our partners. And we've also enacted champion meetings where the 3 champions from each facility meet with a member of our team to talk about stewardship strategies and how to kind of be a successful and very visible champion. We've looked at starting to do some academic detailing for outlier prescribers. And also, we've looked at how to build a structure for internal reporting. How do we feed that information back to prescribers and their leadership? There's communication skills training that's being offered for the champions, and we've thought more and more now about sustainability as our funding kind of comes to a close with this year. How are we going to build a program that maybe doesn't rely so much on the activities of the grant team and will be taken in-house by each of our partners? Okay, so what have we done for each core element, right? This is about implementation of core elements. So for commitment, we didn't really have to get leadership buy-in the way another facility might because we came in with funding. So we were a little bit lucky from that. We didn't have to do a pitch, but a pitch is something to consider if you're starting your own program. And I think a pitch that is a 5-minute elevator pitch would be most helpful. Kind of having it ready in your mind, ready to go whenever you run into this, chief medical officer or whomever. But integrating institutional priorities, it's, we talk about the C-suite and how much they really focus on, perhaps finances of the organization, but they share some priorities that are non-financial, like patient safety, health equity. So integrating that into the pitch, I think, is important. And the implementation package that we're developing, we're going to try to contain some language in there to help guide a pitch. The way that we, during our grant-funded activity period, the way we fulfilled our commitment, since we didn't have to go to leadership as much, was to post NM-branded commitment posters, one of which is over there, basically saying that Northwestern Medicine is committed only to prescribing antibiotics when they're truly needed. For education and expertise, we tried to tackle both patient education and clinician education. And one thing that we thought about was, hey, patients might not all speak English, right? So how do we try to provide those resources? So very nicely, thank you, Kathy. There are CDC brochures that are designed for patient education. I like them a lot. The language is simple. The sentences are short. The layout is very visually appealing. I mean, these are ready and free on the CDC Antibiotic Aware campaign website. So pairing those brochures with the CDC's commitment posters was what we did. And for our community partners, we actually did not use the Northwestern poster. We used the CDC commitment poster, which is also bilingual, by the way. So for education and expertise, so this is a element where we actually spent a lot of time developing various strategies. So for patient education, we also distributed this poster here, which is focused on acute sinusitis. And we'll get back, we're gonna return to sinusitis a couple times, it's a recurring theme. But the reason we like this poster is how it's framed, right? So it's a question and answer type poster. And so patients read this, it's trying to mimic the questions they have and give the evidence-based answer that the practitioner would provide. And really distinguishing viral from bacterial sinusitis, I think many of us in the room know that it's not such a clear distinction, but the poster kind of simplifies it, makes it that kind of clear distinction to kind of say, hey, you don't need to treat viral sinusitis with antibiotics, and that's why making the distinction is important. So another way we tackled education and expertise was institutional guidelines. I alluded to these. So these our ID pharmacists were instrumental in making, and I think they did a couple things in drafting these documents. So number one, they integrated the local antibiotic availability. That was actually a bit of a challenge for us because we realized that some cephalosporins that we thought were available everywhere are not actually routinely available in certain parts of the Chicagoland area. So we had to update our recommendations as to what to use based on pharmacy availability. The pharmacists that we worked with also integrated the antibiogram. Now this is of course the Northwestern Memorial Hospital antibiogram, not the urgent care center antibiogram, but we think we have good capture. And that's how maybe our guidelines might be different than national guidelines. So we created guidelines for acute pharyngitis, acute sinusitis, a lower respiratory tract pneumonia, otitis media, skin and soft tissue, bite, and urinary tract infection. And so I think we're going to return to these, I think, with the next session, and I'm going to go into some depth, but there's a binder clip of that on the table over there. So we laminated these, we posted them in clinician workspaces for easy reference, and we also tried to empower our clinicians with information on how to tackle allergies. So we worked with our allergy specialists to guide the antibiotic selection, and we actually created a table that can help with choosing the cephalosporin in patients that might be candidates for cephalosporins. And really, these guidelines, I mean, they're great. We made them, right? But they can sit on the website and not be accessed. So really, the champions were instrumental in raising awareness, making sure these things are actually used. So here's an example. I picked the sinusitis one. And the reason I think this is, the reason I like these is that there's a consistent organizational structure. So the top, where the text is white and the background is black, these are key stewardship points. And then in each of these, where we thought it was relevant, there's a section for bacteria and a section for viruses. There's a whole half the page is you don't need antibiotics for this type of presentation. And so the top is often the medical decision-making section, then the middle is a treatment section, and the bottom is patient counseling and roadmap. And as I mentioned, these are posted online and at the clinician workstations. So here's the top of the sinusitis one-page guideline. So you can see, yeah, so acute viral, acute bacterial. So we really make it clear that severe sinusitis is these three presentations. And so we make it clear that bacterial sinusitis is not, your garden variety sinusitis. And so here, and I apologize for any color blindness here in the room. So we make consistently the recommendations for adults in a blue background and the recommendations for pediatric patients in a yellow background. And then we have specific text highlighting for different severity allergies where you can have to change your consideration of what type of antibiotic to use. We give duration recommendations, and the doses are all standardized from the pediatric end to mg per kg. So we try to keep it consistent formatting throughout. And at the end, we focus heavily on non-pharmacologic interventions or over-the-counter interventions, really to address that symptomatic misery that patients have, especially with sinusitis. And at the total bottom, we have some key points for when patients should come back and represent to care. So every one of these has this. So moving on to the next core element of tracking and reporting. So this is one area that we spent a lot of time on. We really wanted to collate and visualize data to track performance and feedback to staff in a meaningful way, right? Not just something that was very arcane and removed from any single provider's daily practice. So we focus on making a useful dashboard. And for that, we received a lot of hours from a data analyst who put in a lot of time to develop a high quality dynamic dashboard. We did some validation to try to make sure that our data were accurate. And the end product displays data by region. Northwestern is split up into regions, specific clinician and date, but we also have a number of other filters. So we have diagnosis group. So you think about the 7 one-page guidelines. So each of those diagnoses, but then we also have, sinusitis is a URI, but so is acute pharyngitis. So we have the family and the specific diagnosis filterable. We have representation to care integrated into the dashboard, and we have specific social determinants of health also integrated into the dashboard. And so if you, for example, wanted to look at our dashboard and you said, hey, so how are you guys doing on sinusitis? Like, what's your antibiotic prescribing rate for that? And so I would pull this up. And first, I would make sure the dates align with the dates that you want. So this is the most recent year or so. And you can see here that among all comers, our prescribing rate in the central region. So you're really looking, laser pointer. You're really looking here, right? So this is the central region. Prescription rate is 23.7% for any type of immediate care visit in the central region. But you're asking me about sinusitis. So I'm first going to look at this upper respiratory tract group and find that, oh, maybe our rate is 33.1%. But let's take it a step further and look at sinusitis. It's actually 41.1. That's just the filtering out. It's actually 86.2%. So we thought we were doing not too bad with upper respiratory tract infections, and we realized sinusitis is actually not doing well. So this is one of the really important tools that we developed, and we're trying to take this to the next step of making it a prescribing report card for each clinician. And so some elements of that would include the date range and the prescriber identification, whether we want to make that anonymized or not, some introductory text, a couple of tables, which I'll go through. The first table focuses on the diagnoses where appropriateness is reliably determined without extensive chart review, so no manual chart review for this. The second table is diagnoses where appropriateness may be less clear, but duration recommendations are more uniform, so we can use that. And then the last table is looking at a clinician's top 3 antibiotic choices and comparing those against the guidelines that we developed. So this is just our introductory text on the report card. I won't kind of read it out, but it'll be on the slides. So this is the first table that shows, okay, what is your prescribing rate for upper respiratory tract infection? So you can see there, I've left that blank. I mean, we saw with sinusitis, we had an 86% prescribing rate. So that middle column of best quartile might actually be misleading. You might be in the best quartile of your peers, but that best quartile might be as high as 70%, right? So you need to have the evidence-based APR in that last column to show the gulf between where you should be and maybe where your best peers are, if there's a gulf there. For duration, a similar concept, we had the duration on the most rightmost side. And for the report card, that portion that shows the top 3 antibiotic choices, I just filled this in. So, say a clinician's first and most often choice for treating the very few cases of bacterial sinusitis they see would be amoxicillin clavulanate, but maybe they do ciprofloxacin second. So that's an opportunity for academic detailing, right? Maybe we should be using something else. So this report card, we actually had to go through several layers to get this approved, and we actually haven't given it to clinicians yet because it has to go through several quality administrative reviews before we can actually release it. And at our community partners, it's even more of a process. And so you can develop things, but you want to make sure you loop in the administrators as well, not just the champion and the clinicians. So action for policy and practice. So champions, as I've mentioned several times now, are really critical to involve, and they publicize the steps taken. For us, this element was something that champions really took ownership of and advocated to leadership at community partners regarding policy changes. And so for our action steps, one of the examples was evidence-based treatment recommendations. Well, we made institutional guidelines. One of the other methods was delayed prescribing practices. Well, we talked about that at staff meetings, and we might see a skip later. And in terms of using call centers, nurse hotlines, well, that was a leadership decision that pre-existed our involvement, so we can't take credit for that. And so the next session, I think Dr. Sutton and Dr. Ritter will talk about champions' roles, so I'm not going to talk about this further. I just want to mention a couple final points. So, there are the key steps not named in the core elements. So the core elements talk about naming one person responsible for stewardship. They don't specifically use the term champion, but I think that the champion involvement was critical to our program. And I can't really call it success yet. You saw our sinusitis numbers, but just the increased messaging, I think, is one way of construing success, right? People are aware of what we're doing now. The stewardship curriculum was one tool that the champions used. And we also thought the surveys that we have been implementing were another way that we understood the landscape that maybe didn't come out in the core elements as strongly. And then finally, we spent a lot of time with contracts and scopes of work and service agreements, not a comfort zone for some of us, but these are important things to be able to do if you're doing collaborative agreements with other vendors, other institutions. And so this took a long time, and I want to make sure it's on the slide because it was a key step for us. So some lessons learned. So each of the three settings we've encountered is really difficult in its capacities and culture. So Northwestern has had a stewardship program for a long time. The urgent care centers or immediate care centers at Northwestern have had stewardship presence for a long time. One of our FQHCs has a stewardship team, but it hasn't really gotten off the ground, but has some administrative support. Our other FQHC has no stewardship presence and no administrative support. So these are wildly different settings. So what we can do at each site needs to be guided by that. So we approached implementation not in sequence, but in parallel. I think that helped us build a more robust program, one that will be able to expand as we add more things. And one thing that I realized was there will always be more people to involve and more data to get or to review. But at some point, you're going to have to start your interventions. You can always talk to another person who has some ideas, but you got to start somewhere. And so I think finding that sweet spot is an important task. And part of the urgency to get started is that every step takes longer than you anticipate. And I think being cognizant of that is important. And so I kind of think of the core elements, kind of like a meal kit with the instructions in a language you don't understand. And so I think that what we did, we made a recipe for our facility, and we're going to try to translate that into an implementation package that will be a bit more generalizable, but still practical. That's the important thing. I can't let perfect be the enemy of good when you design things, at least I think in this space. And with that, I'll have questions or we'll move on. Yeah. Hi. Yeah, sure, no problem. So first credit for the surveys goes to Dr. Evans, who's 2 rows ahead of you. So the survey is really focused on, what aspect of each core element is live at the facility that's being surveyed. And so the prescribers got a very, I think, Kathy, you think there was a 1 or 2 minute survey, and the leadership got a much more extensive survey. We provided gift cards, so we did provide an incentive, and even then our response rates were within the 20% to 30% range. But the point of the surveys, at least for the first couple rounds of surveys, we're doing them once a year, is really to see, hey, we're asking these folks if they have access to an ID pharmacist for at the elbow consultation when they see a patient that they want advice on. And so first, what is the distribution of those responses? They really should be all yes or all no. That's not what we found. And then for things that maybe other questions that show more advancing in stewardship, like use of guideline-based order sets or electronic guideline-based clinical decision support. So if we roll something out, do we see that proportion of yes to proportion of no move towards a more unified fashion? So I think that's one way that we're using the surveys, is really we're looking to see things unify. Because sometimes people just read the questions in different ways or think of different things. Yeah. Any other questions? Hi, yeah. Yeah.
How was it developed? Was it self-organically by the grant team or was there a template or software out there that you bring?
So I think that, don't quote me on this, I think it's Power BI. And we had a pre-existing dashboard that was developed by Jeff Linder also at Northwestern, who had done some other stewardship work. His work has a bit more exclusion criteria about which patients don't get included. We looked at all patients, but more diagnoses. So his looked at just URIs. We expanded the field of infections. So I don't know whether our first analyst pulled from that pre-existing dashboard or made it from scratch herself, but she kind of left early on, and now we've had a second analyst who's working with us. So I'm not sure how the design went, and I think it would be hard for us now to kind of figure that out with the staffing change. Yeah.
Sorry, I was planted here by Jamie to come here and just remind, because of all the work that it does take to develop these dashboards, that's why the Department of Health has, asked us to come in and offer to work with interested health systems to develop dashboards at no cost to the health system. So we do have full-time data analysts. We've gone through all the validation and everything that was talked about, and so that's what we're here trying to do, to offer that service to the health systems in Illinois, so you can not worry about that, because not everybody's got the resources or the bandwidth to hire a full-time data analyst. And then that way you can take the other elements that they've shown from the to operationalize and go forward with that. So I just want to let you guys know that we'll be a resource for you guys.
Everybody that knew the charm program, right?
Yes, I'm with the CHARP program, sorry.
Yeah. And
I'm just some random guy who shows up.
I would say that I attended the CHARM talk last year, and if I had known about CHARM before we started our project, I think there would have been a very good chance that we would have gone with CHARM. I think it's good that we have a dashboard that really addresses some of the subtleties of Northwestern, but I think the development time for our dashboard has been very long. And again, perfect is the enemy of good. I think it would have been helpful for us to have some of that data earlier on and start stewardship implementation earlier on, and really maybe be seeing outcomes at this point that we now are going to probably wait another year to see. Yeah. Yeah. So I think the goal has really been to try to, appoint champions at our partners, have the champions demonstrate their value to their organization so that our grant activities can persist in some way with internal funding once the grant kind of ends. Yeah. Yeah.
Knowing that is not available, so I want to know how do you measure the program by doing education, because it's getting patients as well and providers. How do you measure that the program is really efficient?
Yeah, so our data you're asking where do our prescribing data come from, if I'm interpreting your question correctly?
After doing the education.
Yeah.
The program,
yeah.
How do you measure the efficiency?
Yeah, so we are not measuring how impactful patient education is. I think, the patient education is fairly passive. It's posters on the wall, it's brochures. I think for provider education, we have a bit more tools to measure efficiency. So if you look at the prescribing rate, maybe that should go down. But I think the better measure for this might be that last table I showed that has the top 3 antibiotics for each provider for each infection. So if we see these migrate towards the recommendations we put on our guidelines, I think that will show us that the education that we're doing for providers is more impactful. Okay, well, with that, I will step down. Thank you.